or was used. In the studies, the assumed common odds ratio across all stratifying variables was calculated using the Mantel-Haenszel method. To derive the pooled estimates, the Dar-Simonian and Laird random effects model was used, which removed the confounding by unknown genetic and environmental variables. To visually assess the odds ratio estimates and corresponding 95% confidence intervals across the study, a forest plot was generated. Next. A higher prevalence of poverty, anemia, poor nutritional status, dehydration may increase the incidence of cerebral venous sinus thrombosis. It was more seen in developing countries as compared to the developed countries. Hence, stratification was done of all included studies by prevalence of hormonal contraceptive use and by developed and developing countries. Statistical heterogeneity for the pooled odds ratio was evaluated using the I-square statistic and the Cochrane Q statistic. Testing for publication bias using Begg's rank correlation test was for small study effects. All the p-values are two-sided, with p-value less than 0.05 was considered as statistically significant. Okay, so next slide, sir. The results study identification and selection. Of the 50 studies selected for full text reviews, only 11 studies were included in the systematic review. Of these 11 studies, only 2 studies reported on an association between the use of third-generation OCPs and the risk of CVST. Nonetheless, the data reported in these studies was such that we could not estimate an odds ratio for CVST in women taking OCPs versus those not taking them. Thus, only 9 of 11 studies contain sufficient information for a meta-analysis to calculate the pooled odds of CVST. So next slide, yeah. Next, yeah. These 9 studies were in English language. Study period ranged from 1996 to 2005. All were case control studies. 2 studies were multi-center and 3 were from developed countries. Total subject ranged from 32 to 2288. All the studies reported only on the use of oral contraceptives. Only 2 studies reported on the duration of exposure to oral contraceptives. Next. The study quality. Of the 9 studies included, the quality ranged from moderate to high. 4 studies had well-defined cases and 5 studies had well-defined controls. Controls were matched to case characteristics in 5 studies. Exposure to hormonal contraceptive within 2 weeks prior to CVST in cases and study assessment in controls was recorded in only 3 studies. Potential confounders and modifiers were discussed in 5 studies to varying extents. Variable adjustment for these factors so occurred in the same 5 studies. Next slide. In the diagram, you can see in the flowchart that in all the cases that controls are more as compared to the cases. The 2 studies were considered Martin et al. In 1996 and Cantu et al. Study. Okay, next slide, sir. The effect of hormonal contraceptive use on occurrence of CVST. All the 9 studies show an association, that is, the use of OC pills increases the odds of developing CVST. Among the 9 studies that reported the odds ratio, the pooled odds of developing CVST in women of reproductive age taking OCPs was 7.5 times the odds of developing CVST for those not taking the OCPs. The 2 studies that reported on the use of third-generation OCPs suggested that the use of these newer generation OCPs was associated with an increased risk of CVST. Bridgen et al. Assessed the risk of CVST with third-generation OCPs and found an odds ratio of 2 for risk of CVST with third-generation OCPs as compared to other OCPs. Next. In this diagram, we have studied the 3 studies: FDA-funded study, international study, and European activity. It is also seen in this diagram that third-generation OCPs have a higher risk of developing CVST as compared to the first and second-generation OCPs. Next slide. The incidence rate ratio IRR for CVST per 1 lakh women years was 2.7 for days with desogestrel, 1.6 with norgestimate, 0.7% with levonorgestrel, and 0 with conceptive patch. The incident rate for non-exposed women was 0.4 per 1 lakh women years. So next slide. Next slide. Discussion. It was found that the odds of CVST in women of reproductive age exposed to oral contraceptives was about 7-fold higher than the odds of CVST in not taking the oral contraceptive. This estimate is comparable to a previous meta-analysis 7 years ago. In addition, the review showed that there was insufficient evidence on the relative safety of third-generation OCPL when compared to previous generation OCPLs in increasing the odds of CVST. No data were found on the duration of exposure to OCPLs and odds of CVST. So next slide. Yeah. In addition, the odds of CVST with OCP use is not significantly different in developing and developed countries. The review also showed that the odds of CVST with the use of other hormonal contraceptives is also largely unknown. Variables such as age, smoking, and prothrombotic genetic mutations can certainly contribute to risk of CVST and influence the results obtained. Meta-regression, however, did not identify these variables as contributing to the study heterogeneity either. The prevalence of CVST in developing countries is far more than in the developed countries. The results led us to speculate that the independent biological effects of OCPs on thrombosis may be stronger than of the relationship between the OCP use and risk of CVST by factors such as malnutrition, dehydration, and anemia. Studies from sub-Saharan Africa or South Asia regions of the world where malnutrition and anemia are more common show low risk. Beck's test does not tell us to directly identify to the direction of this class. Interestingly, the funnel plot shows the absence of small studies reporting on a positive association between the use of OCPs and CVST. Next slide. Only 2 studies reporting on the risk of CVST with the use of third generation OCPs was found. The third generation OCPs are combined OCPs containing androstenedione or desogestrel that were developed to reduce the risk of cardiovascular disease. There is controversy as to whether the third generation OCPs are associated with the increased risk of venous thrombosis compared to second generation OCPs. The biological basis of increased risk could be a differential effect on various coagulation factors, resulting in overall increased thrombogenicity. So next slide, please. Other studies, including a detailed meta-analysis refuting the biases like the healthy user bias, prescribing bias, referral bias, suggests that third generation OCPs put women at a higher risk of developing the venous thrombosis. The review of the literature to the current time leads to conclude that no definite recommendations can be made in favor of the safety of third generation OCPs. Furthermore, in such women, non-hormonal contraceptives are preferred. No major studies assessing the risk of CVST with the use of other hormonal contraceptives such as contraceptive rings or transdermal patches. So next slide, please. So next slide, please. The study has limitation. The biases inherent in a case control study design can influence the summary. Residual confounding factors by variables not studies or unknown could always exist. An interaction between the risk factors of CVST and hormonal contraceptive use was not reported in most studies and therefore could not be explored in detail. Despite the limitation of doing a meta-analysis of case control study, the study has several strengths. First, the CVST was objectively confirmed in all the studies. Second, it can conclude whether confidence that the odds of CVST is increased with the use of OCPs as compared to individuals not using the OCPs. The studies in this area consistently show this association. In addition, the cumulative meta-analysis demonstrates that this association holds true and strengthens with time. This association also has biological plausibility. So next slide, please. The part of the issue in studying the CVST is the rarity of the disorder and the inability to study it in large cohort studies or randomized controlled trials. Therefore, case control studies remain the most feasible design in studying the CVST. Variables that increase the risk of CVST, such as the pregnancy or the postpartum period, prothrombotic genetic mutation, and head trauma, should be excluded in both the controls and cases and the controls. The control should be matched to cases by age, BMI, socioeconomic status, etc. Duration and type of hormonal contraceptive use and its timing in relation to CVST for cases to study assessment or control should be documented and then analyzed in the results. Final analysis of results should include an overall estimate of effect, but also subgroup analysis to look at the variables such as the type of hormonal contraception, duration, and timing of use. So next slide. So next slide. And in conclusion, oral contraceptive use increases the risk of CVST in women of reproductive age 7-fold when compared to those not using this method of contraception. This systematic review suggests the need for future studies to answer whether duration and type of hormonal contraceptive use modifies the risk of developing CVST. However, based on our review of the literature, we would recommend that women with other risk factors for thrombosis, such as smoking, immobility, history of thrombosis, or thrombophilia, or a past history of CVST, choose an alternative non-hormonal method of contraception. Yes, sir. Next slide. Yes. Yes, sir. Thank you, sir. I have finished my presentation. So thank you. Thanks, sir.
Dr. Chaitanya, you have to unmute.
Okay.
Thank you.
Thank you. Yeah. Thank you, Ameya, for that wonderful presentation. You have compiled or concised it quite nicely. And we know that this study basically is a systematic review and meta-analysis. Now, when we say systematic review and meta-analysis, the first question comes to most of our minds is that what is this systematic review? And what do you mean by meta-analysis? What exactly needs to be taken out of it? And for this, we are going to have our next speaker, and I am going to ask my colleague, Dr. Meenu, to introduce our next speaker, Dr. Raju Nair. Over to you, Dr. Meenu.
Thank you, Dr. Chaitanya. And as rightly said, we are really awaiting for this talk because we'll all understand what exactly do we mean by a systematic review and meta-analysis. So for this, we'll like to invite Dr. Raju Nair. He is a fellow in reproductive medicine from CMC Vellore and currently the director and head of reproductive medicine in Maitera Hospital, Kottayam, Kerala. He's also been the president of Kottayam OG Society and the past secretary Kottayam OG Society. So welcome, Dr. Raju Nair. Over to you.
Thank you, ma'am. Am I audible?
Yes, sir, you are.
Yeah. Basically, the topic today is a review on systemic review and meta-analysis. And the previous speaker, Ameya, has actually narrated one meta-analysis. And this meta-analysis, the basic problem of that meta-analysis is that usually meta-analysis is an analysis of much more evidence-based stuff. That means any randomized controlled trial, and we analyze many randomized controlled trials to come to a more conclusive data. But here he's rightly pointed out, particular topic does not have much of an RCT to conclude, to take. Then obviously, is basically on a general overview of what is systemic review or how you actually do a meta-analysis in liaison with this present review article. So we are living in a world of evidence-based medicine. So why this evidence is very important in healthcare? Because it should have a clinical effectiveness. Because does it work? And whether is it safe and whether it does, we can afford it. Because we know that pharmacology industry is ever developing and newer molecules are coming up. And the pharma industry biased data is very much there, and we will be sometimes very much biased for what the pharmacology colleague or the medical representatives tell us, and will be biased with that. So in order to get a conclusion whether what they're telling is correct, we actually look how effective the study design and very effectively understand how to read a journal article to get the best out of it. So what is a systematic review? Systematic review attempt to collect all empirical evidence that fits a predefined eligibility criteria in order to answer a specific research question. It utilizes explicit systematic methods that are selected with a view to minimize bias, thus providing more reliable finding from which conclusion can be drawn and a decision is made. Because if you look into the evidence pyramid, the meta-analysis and the reviews or the Cochrane reviews come always in the top. But majority of time, we get the data from the internet or a case report or the present data of case control studies, cohort studies, where all actually come very much low in the evidence pyramid. So ideally, this primary studies, whether it's a case control cohort or randomized control trial, if you look into the evidence, RCTs will come in the prior. So case control studies, if any known RCTs are not available, then definitely we go for this. And suppose we have, say, 10 RCTs, and 10 RCTs will be done at different groups and different world population. So if you can have a control or rather analysis of different RCTs by doing a meta-analysis, we will be able to get a more clearer view of that objective. So that is the beauty of a meta-analysis. So the systematic review process concludes, first identify the research question and define the inclusion and exclusion criteria, search for the studies, select the studies, extract and synthesis. So this is in a nutshell how we do a systematic review. So definitely the most important question is to identify a question. It's a time-consuming thing because in the present topic we discussed, hormonal contraceptives and cerebral venous thrombosis risk, a systematic review and meta-analysis. The problem is this has got a broader definition because it is not defining to a particular group it is a generalized statement is put up. But if the same question, if you put up in a different way, that means answerable question, that is called PICO question. P means a description of the population, identified intervention, what intervention has been done, and any comparison has been done, and what is outcome. So if you look into this literature, they actually identified this because they put the P, population of women of 15 to 50 years, intervention, OCP treatment, comparison, non-OCP treatment, and the outcome of presence of CVST. So with this, they're actually getting into a good research question, whether the woman who are aged 15 to 50 years using OCP has increased risk of developing into CVST compared with the non-users of OCP. And along with the non-users of OCP and the OCP, different types of OCPs and the different other variables were also tried to assess as a subgroup analysis, which they failed miserably because the data were not sufficient enough. So the inclusion criteria that what they mentioned is very clear, because what is included and what is excluded very much clear, and the randomized control trials were not feasible. So cohort studies and the case control studies were most commonly employed. So they definitely define what were the inclusion criteria and the exclusion criteria. Then coming to the most important part of the topic, that is literature search. We know that a literature search is like putting the head into the haystack, because we know the evidence or the literature in the internet is so huge. So what is a relevant search and what is a irrelevant research is actually so huge. So suppose we need in this complete, suppose if you just put a Google Scholar and type on this thing, you will get say maybe thousands of or maybe hundreds of literatures. So from this, how you become a definite or rather the point specific answer from that particular journal or particular search is actually a difficult task. Here, but the most important thing is your concept of research question, from a broad questions to narrow questions. Because if you put your questions to a narrow, then highly directly relevant articles will get. But if you just put a very broad question like ladies using OC pills and the CVST risk, you will get enough and plenty, and you will not be able to. Maybe you will get 1,000 literature search. But if you define to 15 to 50 years group and using third generation OC pills, you are narrowing it down. So the beauty of research is actually how effectively you can put up the research question into place. So how focused question helps in research, because the patient or the problem, the interventions and outcome. If these three things comes, you can definitely say it comes to the most likely question to address. And obviously we can put the study design later, that we check only RCTs or we check only case control studies when we are actually narrowing down. So this is how, in nutshell, how you analyze or rather go further into the literature search. So a good research question has got a clear research question and a comprehensive search of all domains, no language restriction, unpublished and published literature, and should be up to date, and document the search. That means replicability should be there. So where to search? Obviously, now the world of internet, the world is so narrow in your fingerprints. So electronic database is the best. So we have Medline, Embase, Cochrane, PsycInfo, Scopus, many things. And the press checklist, Open Gray for Gray literature for Europe. And there are Central, PubMed, CDC, NICE guidelines, and obviously Google Scholar. So there are many data or data banks available to do this searching. Problem is that different data bank has got a different type of assessing this database. That means even the bibliographic database is different. So you should have a better understanding of this bibliographic concern. And obviously, as doctors, we may have a tough time. So your librarians are your best help to help you in doing with this data search. So basically, the components of electronic searching is, one is the PICO component, that the question, and start with the primary concept and find synonyms. There are two things I should explain. One is the concept of mesh. That is that means if you put child along with asterisk, then it comes as a mesh. That means a medical subject heading. So child with mesh will return children, childbearing, childbirth, and so on. So you will get a lot of information by putting this merge terms as your keywords or synonyms. And second is Boolean operators. That means if Boolean operators are and or not. Suppose you want to get information from dog and cat, put this symbol plus. Suppose you want information from dog or cat, put this slash. You will get a lot of information. Dogs, not cat. That means a small hyphen, you will get only dogs. So this is called Boolean operators. With this Boolean operators and mesh, you are able to do a good research, even in your PubMed search or in Medscape search, you will get a better understanding. And the study design filters, if you go with your library colleagues, they will put the study design filters also to define or narrow down the search. And this data of published literature is little more easy, but there is a huge area of unpublished literature. So when you go for a meta-analysis, it's always important to look for this unpublished literature, because only 25% of all medical journals are in MedLife, because 75% is actually lying outside. But the problem is it concerns a lot of publication bias, and there are many bias. So we have to be very careful in selecting this unpublished literature. So what we have to do, we may sometimes go to hand searching of the key journals and the conference proceeding. Suppose you may have to contact agencies or peoples like quintiles who do RCTs or academic institute and say go to a defined hospital library to get this literature, because many thesis topic where people has done this literature but it is not published. So, but if you go to this particular university and go to thesis topics, you will get to know these have been registered with CTRI. So definitely we'll get a more database. So unpublished literature is also a big avenue to deal with. And take my word, as doctors, it is difficult for us. So obviously your librarians are your best friends. Input from the search specialist is always advised. And if you do a Cochrane review, this search specialist is provided by the Cochrane, because they will help you in narrowing down your search. Then coming to your headache, that means the search is done, then you have to select the studies, extract the data, and assess the quality. That is the preview of the principal observer. So from the reference retrieved from the search, the deduplicated references, eligible studies after abstract screening is confined, and the eligible study for full search screening, because this is a flow. Suppose we have, say, 857 for this particular study. We have 857 original citations. Of this 861, and finally we selected up to 50. Of this 50, only 11 were actually assessed. So this is called screening. So how we do this? For this, we have two softwares. Both are freely available in the net. One is called Covidence and one is called from the Cochrane, Revman. So Covidence is an easy task. Revman, especially if you're liaised with the Cochrane, Revman is also good. But both these things will give you a little easy tool for doing this abstract screening. So basically, why you need to do this abstract screening is basically to assess the quality of study. Because when we assess the quality, because if a poor quality trials are the building blocks of the review, then the review may follow high quality methods, but the quality evidence still may be poor. Because if you just see this clean image, but if the background is poor, definitely your quality of evidence will be poor and you will get a bad biasing, because this is going to affect our population. So we have to be very clear in the assessing the quality of study, because a concept called bias. Bias is a systematic error introduced into sampling or testing by favoring one outcome over the another. And if the study is biased, it can understate or overstate the true effect of an intervention. There are different types of bias, and especially we think that why RCTs is given as a best way of primary study, because RCTs will do a more of less biasing tools. So first is randomization. That means we have an intervention and control. So with randomization, we are avoiding the so-called selection bias by concealment of allocation. And they are blinding the participant. So the performance bias is avoided. By equal treatment, we can go for how many people are drop out. The attrition bias can be calculated, and the detection bias by blinding. So many bias can be, to a limit, avoided by random RCTs. But by case control study and cohort study, this biasing has got high chances. That is why, especially when we go for a meta-analysis, RCTs are the preferred one to do meta-analysis than the case control study. But in this scenario where RCTs may not be possible, obviously case control study can be used. Then how you do? you should have two independent reviewers. And here, one Bijoy and Rick Sove, they are the two independent reviewers. So first they do an abstract screening. So they take up one study and read the abstract. And in abstract, what they wrote, they take this abstract into three headings. No, that means this article does not meet the inclusion and should not be included, because they decided. As individually they decide and the third party agrees to it. And maybe, that means that not information in the title abstract make the decision, but definitely we may screen the full text, that we keep the maybe list. And yes, okay, this article meets your inclusion, it has to be completed. So from this abstract screening, we narrow down from 50 to 11. And that 11, we go for a full test screening. Here also we can go include and exclude. Include that article meets the inclusion and should be included in the systematic review. Exclude the article does not meet the inclusion criteria and should not be included. So the voting is blinded. You individually has to take the call, but you have to follow your principal protocol. That if your protocol should be defined and you have to go with that. So once you do this, I told you there is a Cochrane Revman software and the Covidence software. Both has got different ways of assessing the bias. That means different biases has to be analyzed. Random sequence generation. There we will check the inclusion criteria, whether the random sequence has been done or not. Allocation concealment has been done or not. Blinding has been done or not. Accordingly, we put our data here. So if anybody has gone through the Cochrane database review, you can see that there's something called risk of bias tool. And the risk of bias tool, how you gather is that in the back end, each study, that education concealment, incomplete outcome, all these have got a heading, and we add our data in as an individual. And the risk of bias graph will be there. So each individual, has got a graph like this, and the bias summary will be like this. So looking at this summary, we can see this particular article number 4 has got a lot of bias, and education concealment is very good. So from each studies, all these different types of bias can be assessed. So that is the beauty or the advantage of a meta-analysis. And like this, the risk of bias table has to be provided for any article which you are taken into. And in Covidence also same thing. So here what they do is that this is the Covidence trial. So we have an article like this, say uterine flushing of the supernatant embryo culture vitrified warm blast, a randomized trial. So we have different concealment, and we do this data low risk, high risk, unclear, and accordingly this data will be compiled, and this later on will go to something called Prisma flowchart. This also is really a software-based thing. There's something called STEC, Shiny apps. You will get this Prisma flowchart, and you have to enter how many studies were included, how many were there, and automatically you will get this Prisma chart. So this also should be incorporated with your study plan. Then you identified the question, you identified your search, and you narrow down your search. And second, the last part is the data extraction. This is actually a simple thing, or rather, the most important thing, but we might have done the homework beautifully so that the process is a little easy. So here also, you have to be very clear with the methodology, population, intervention, and outcome. And the level of judgment, how much to it is also very clear, because you should not go for unnecessary details. So here, what they do is that the population, interventions, outcomes are individually assessed, and we can save. And you come to a final summary of the meta-analysis, is something called the forest plot. Here in this present study, we saw that there's a forest plot of almost 8 or 9 studies, and the overall significance showing 7.5. That means 7 times the risk of odds ratio. So what it actually means, I'll explain to you, because these are the different studies of case control studies they assessed. So suppose you are putting this in a forest plot in Roman. Suppose we have 7 or 8 studies. The study 1, intervention and control, how many events and how many total. So you can put these numbers one by one, depending on your study criteria, because this data is there in your literature. Suppose study number 1 is total 20 patients were evaluated, 3 had the CSVT, and the control 20 patients were had CSVT. So like this, 7 or 8 studies were there, give you a graph. By default graph, like if you press this click, you will get a graph like forest plot. So this is where the problem of skewing comes. That means suppose we have only 20 patients here and one study will give you 109 cases. That means it will have got a bigger square. So that will sometimes skew the entire data to one side or to one side. That is the problem of sometimes with the meta-analysis. So you have to be a little careful on that, because if the final outcome is skewed to one due to one particular study, then the risk of biases will be more in that. So for PGs or juniors consultant, how to analyze a forest plot analysis. This is how a simple forest plot looks like. It's actually comparing low versus high oxygen concentration in embryo culture live birth rate of the clinical pregnancy rate. It says that low oxygen tension will increases the pregnancy outcome. So what it actually means, just by looking at this graph, the overall effect, that means if it crosses the 1 and is not touching the 1, that is starts from 1.08 to 1.67. That means it has got a significance. That overall is diagonal pyramid. And the weight of study that I told you is, suppose one study has got total 321 patients. That means it's a broad square. And some studies will be very less, 24 studies, it will be very narrow. So the weight of studies can be assessed by this. And this entire graph from one point part to this thing is called the confidence interval. And this confidence interval is very well demarcated here also. So this is diagonally represented, systematically represented in this part. That's the confidence interval of each study. Then the weight is already established, and the whole study confidence interval is also mentioned about the initial diagonal. This is actually what we are actually looking at, the final endpoint. And the test of significance, that the statistical significance of this value, whether the p-value is less than 0.05, definitely significant. So if he has got a positive correlation overall effect and with a high significance, we can take that this has got a merit. And there's something called funnel plot. This funnel plot is basically to assess the publication price. I am not very clear on this aspect, but what I gather is that there's actually a funneling, and majority of the studies which comes within that group, then you can see that the publication price is not much. I'm not very confident on what this exactly, because if we are doing maybe 50 or 60 studies for analysis, then only this publication price come into play. So coming to our particular topic today, whether hormonal contraceptive and cerebral venous thrombosis, the systematic review, they studied of the 861 studies, 11 were included. The pool's odds ratio shows that 72%. That means p-value is very significant. That 7.59, that is the times woman not taking OCP with the risk. That means it has got a very high significance. But when they initially planned this study, because this data is already there in the previous literature, so the present study doesn't, their main objective was to add whether a newer generation pill or other variation with the developing countries and the newer all sort of pill has got any contributive effect. But unfortunately, they are unable to find the data on that. So they conclude data were insufficient to make conclusions about the duration of use and other forms of hormonal contraceptive. But in the narration, they enlighten their thoughts. But that thoughts should not be taken into consideration, because unless we get more and more evidence to prove, we cannot categorically say that the newer generation pills are safe or the older generation safe or unsafe. That is a charm of an evidence-based medicine, because unless the newer evidence come, more and more data comes, then you will get a confirmed idea of whether it's useful or not. And obviously, after 10 years down the line, we may feel that what you are learning is absolutely wrong, because the new data will change everything. That is the charm of an evidence-based medicine. So to conclude, the most important question is identify the question, clear your inclusion-exclusion criteria, and a comprehensive research search with the help of a librarian. And obviously, you need training. This Cochrane, South Asian Cochrane Network is giving all these things free of cost. And input from the search specialist is advised. Study selection needs clarity and eligibility. Data extraction is time-consuming, but this is the most important aspect. If you do this good, the remaining part will be better. Then adequate software knowledge. It is not that difficult, because you're doing in a teamwork. It will be you can easily license with your friends, and needs a combined team effort. The bottom line of any statistical analysis or a meta-analysis is that it is nothing but a teamwork. Thank you. Thank you.
Dr. Meenu.
Thank you, Dr. Raju. I think this was a very, very crisp, and I think all of us have really understood it very well. You made things look so easy for all to understand the concept of systematic and meta-analysis. So thank you so much. And anything else, Dr. Chaitanya, would you like to add on Dr. Raju's excellent talk?
I want to tell.
Yeah, Dr.
It was indeed at in-depth knowledge about it, and thank you, Dr. Raju. You did a wonderful job. Thanks for it, sir.
Thank you, Dr. Raju. I call him Raju because we are friends. We have been together for 3 years of residency. The only thing was the institutes were different. He is passed out from a very premium institute, one of its kind, Armed Forces Medical College. So we are batchmates to that extent. Thank you, Raju, for that wonderful talk.
Dr. Chaitanya, I think Surekha ma'am has asked a question that what sort of team do you need for a systemic review and meta-analysis? Please, Dr. Raju, enlighten.
Madam, for a systematic review, you need first a clinician. Basically, if you and your friend, because you can team up well, 2 persons as a principal observer, and then you should have a biostatistician if you have, then they will analyze the intricacies of different tests you should do. Because in this test, analysis of the case control studies to do a meta-analysis, something called MOOS, and for RCTs is different. So that information we may not have. So a biostatistician is always helpful. And the third most important person is a search specialist. And any librarian will do this job. And if you are interested in CMC Vellore, there's actually a South Asian Cochrane Network review group is there. And they do this training programs for all of us. So I think once in 6 months or so, it will be it's an online program, and maybe 2 or 3 days, you will get an idea about how to do this. And my friend, myself and Chaitanya's friend, Dr. Mohan Kamath, he is actually is into it, and is actually one of the, South Asian zone coordinator for this systematic review and meta-analysis.
Yeah, we are going to have him sometime on this program as well.
Dr. Raju, once we have the protocol ready, I think we need to publish the protocol also. Yes, in every systematic analysis and review. Once we have the whole inclusion, exclusion criteria and the whole thing is ready, you have to publish it also first, right? The protocol has to be published.
Yeah, the first thing is protocol publication. And once the protocol is ready, then only you can do this study.
Yeah.
And both protocol and the study will consider as 2 journals for you. Those who are in medical college, those who want to pile up your journals, both protocol as well as the study will be considered as 2 different articles.
Exactly.
So thank you, Dr. Raju, for that wonderful presentation. Moving ahead, just a quick comment that Dr. Chandrika is the one who is, pioneering, or what you can say, she is the one who is collecting these articles from different journals. And then we are going through that articles, and then we are selecting those articles to be presented in these programs. Am I right, Dr. Aki?
Yes. She is also the coordinator of endocrinology committee, and she was one of the brainchild where we are. This Endolit has come forward to.
Yeah. Thank you so much. It is just that there is so much of learning with each journal, and this idea, Dr. Aki immediately took it up, and thanks her, was very, very helpful in guiding us in doing this Endolit series. But it is such a very, very different kind of a journal club we are having, very different learning experience. Chaitanya, very good choice. You got your friend Dr. Raju. It's very, very clear now. Thanks, Doctor.
Yeah. And moving on ahead, we've got Dr. Basab Mukherjee for the next talk. And Dr. Basab Mukherjee is the Vice President of FOXI at present.
Let me share.
Yes, please share. And I would like to tell that we all 3 committees are under Dr. Basab, and it was him encouraging that let's go with all the committees and licensings to be done. And here we are with all the 3 committees together.
Are you seeing my screen?
Yes. But we would like to have Dr. Basab's CV.
Yes. I think it was before this. Yes.
That is Dr. Tanks. Just before that.
You are not seeing Dr. Basab, sirs?
No.
No?
After this? Yes.
Okay.
We've got a dynamic vice president with us, Dr. Basab, and he is a FIGO coordinator for South Asia. Safe Abortion Committee, clinical examiner for RCOG examinations in India, member governing council of ICOG from 15 to 20, and honorary secretary of Bengal OB-GYN Society from 18 to 19, young gynecologist awardee for AOFOG in 2011, and past chair for Family Welfare Committee, and vice president of FOXY at present, and organizing secretary of AICOG 22, which would be held in 23 in, if I'm not wrong.
Thank you, Raki. Thank you very much. It's wonderful seeing you and connecting with Dr. Binu, Dr. Chaitanya, Dr. Chandrika. Hello.
Good evening, sir.
And it's a pleasure being here.
Good evening, sir.
Season 1. Good evening. Season 1, episode 4. That's what your that's what Endolit is. So season 1, episode 4. So we congratulate you for the 4th episode of the season. And I'm sure you'll have more seasons to come and more episodes to go. It's a wonderful program, as Dr. Chandrika and all of you have appreciated. It's really wonderful. There were some really nice talks which I was privileged to listen. Dr. Raju, and before that, Dr. Ameya. And also good, nice words about CMC Vellore, my alumni too. So my alma mater, and it's always wonderful to hear good things about your medical college. So just a few, I move ahead. I take it a little lighter because it was really heavy and very nice, concentrated science. I need to share my screen. Somebody needs to give me permission for that.
Rahul, you need to make sir host.
Yes, sir. I'm just doing.
Actually, we're also getting a little off our normal online skills, but these have to remain because even after the physical meetings come up, they will be a small part of we having online stuff again. Yeah, I've got it. Thank you, Raju. Thank you very much. So over the next 10 to 12 minutes, I won't take more than that. We'll just take you about something which is a little mundane compared to the wonderful systematic meta-analysis and systemic reviews which you heard from Dr. Raju. So this is about myths and facts about contraception. I thank Raki for giving me a much simpler topic than what we dealt with before. This is something again which we have discussed on multiple occasions and multiple forums, but this is a little different. The greatest enemy of knowledge is not ignorance. It is the illusion of knowledge, said Stephen Hawking, and how correct he was that when we talk to people around us, when it comes to myths and misconceptions, a lot of people think that that is actually the truth. So it's not ignorance where people don't know what they are, what they need to know. It's about the illusion of knowledge, and that is what is surrounding all of us. And even in the COVID pandemic, we heard that the problem was not of information, the problem was of misinformation and disinformation, which was going all around, which created more of the problems. So whenever we talk about this topic about myths, and whenever we go out to the colleges, schools, corporates to discuss about family planning, birth control, one of the ways in which we generally start is the source of where health information comes in. And we know that now in this day and world, the sources for health information are enormous. You have the great big internet, which is elephant in the room. But again, you have got your friends, you've got family, you've got neighbors, you've got the pharmacy shop, you've got magazines, you've got journals, and you've got other sources of health information, all besides your good and friendly healthcare provider. So I think that's a very important part, because when you get so bombarded with information, and when you get bombarded with myths and different kinds of information, it's very difficult to filter what is correct. It is very difficult to understand what should be the truth. And so that's why myths regarding any healthcare system, especially in birth control and contraception, has a lot of challenges when we want to really address them and make a difference at any level. So what are myths? Myths are generated by the ignorant and the ill-informed. So it's sometime down the line, somebody had picked up something which sounded logical, wasn't backed by science at that time, but that is what myths, how they come into the picture and how they develop. Myths often remain constant. It doesn't change over time. So a myth will remain the same across generations, across decades. So one myth which will be heard once doesn't keep on changing. It remains constant, defies science. There's nothing about your meta-analysis or systemic reviews which can change myths, because that science goes very slowly, information goes very fast. So if something comes up on a newspaper, that possibly is taken more as truth than a randomized controlled trial, because that information isn't disseminated enough. Myths often strengthen with time and cross generations. We've seen it in so many cases, especially related to birth control methods and contraception, that the myth is often assumed as a truth. And there's something like you don't think it's a myth anymore. So it's obvious this is what the truth is. They get peddled over time as a truth. And so after some time, it's similar in politics also. When you keep on saying the same thing again and again and again and again, even though it's a lie, the way you get yourself, where you get your audience to get convinced, they say, after some time, they say, I think this is what the truth generally is. Myths affect compliance and continuation of birth control methods when we're talking about contraception. So there are important things which need to be addressed, important things which need to be discussed. I remember when the family planning committee, family welfare committee, when I was chair and also when other people were chair, they had series of CMEs on myths and misconceptions regarding birth control methods. And one of the target audience was not just gynecologists, they were general practitioners also. So myths are early science, the result of men's first trying to explain what they saw around them, said Edith Hamilton. And so it's something which hasn't really changed since then. So because it's a talk, to make this a little light, let us see what are the general myths of birth control which we have. So a lot of people think that birth control is 100% effective. In your clinic, you would see patients on a daily basis who, after using emergency contraception, are so surprised how they became pregnant. Or even after using a condom, are so surprised how they became pregnant because they used a condom. But birth control is never 100% effective. We know that, but they don't know it. And it's a myth that they think that if they use something, it has to work. So effectiveness of methods vary. Then you come up with your chart about the different percentages of how much what is effective, the most effective method, the least effective method, and then they possibly nod their head and say, okay, now I know a little better than what I knew before. There's no need for birth control if you have sex during the safe period, because it is safe. But then we understand that this is one of the least effective methods of birth control, because the time of ovulation is variable. It's not that safe what you think is safe. And sometimes periods are irregular. And so anytime you can get pregnant. But again, that's something, again, which is a myth. You can't get pregnant with coitus interruptus. If you have the ejaculate outside, how can you be pregnant? But who will tell them about the pre-ejaculate, which also has sperms? If you douche after sex, then you can't be pregnant. Who will tell them that douching is bad? Not just because it doesn't wash off all the sperms. First of all, you still can become pregnant. But worse comes, it also takes off your good bacteria, your probiotic, your microbiome, vaginal microbiome suddenly changes, and you are increasingly prone to infections. Can't get pregnant at the first intercourse or during menses or during breastfeeding. There's several myths which all there around, but at the first intercourse, there's nothing different from the next. And during menses, of course, your chances of pregnancy are much less, but not zero. And during breastfeeding, of course, you can be pregnant. Again, depends on how much breastfeeding, how much of a lamb protection you have. Otherwise, it's not much different. So why do healthcare providers need to know about these myths? So why are we taking this talk, or why does Raki think it's so important to include in this seminar? Well, it will have to be incorporated into your counseling. So once you talk about your basket of choices, once you talk about a couple of methods which a person will adopt, you may try to bring in some of the myths which either they have heard, they're hesitant to tell you in the clinic because they may get get a scolding, or they may not have, or they may hear once they go back home, and they may not use your medicine at all. So it may be brought up initially in the discussion counseling. That depends also on how long you're talking to them. A contraceptive counseling ideally should take around at least 10 to 12 minutes. But if you're very busy in an OPD and you don't have privacy, you can't talk that long, then possibly you need to skip all that. But at the same time, it could be brought up initially, or if clarifications are sought. So sometimes they may say, doctor, are you sure that this is the best for me? Because I've heard something like this, I've heard something like that. So if once you have developed a rapport with your patient, you become more pally, then of course they bring up all these, and then it's more like a friendly discussion rather than a client and a healthcare provider discussion. So also you can use the myths in IEC material, information, education, counseling material can be used for communication, where you can use a lot of these myths can be put up in pictorial form, where it can drive a point when a lot of people tend to believe things which are printed and which are put up on a chart rather than what you're saying verbally in a clinic, because what things which are printed, things which are there possibly are perceived as truth more than what is verbally pronounced. Will not be unprepared when it comes up. If somebody says the copper T can migrate or something, you don't have to burst into a laugh into the clinic if you know that this is something which people sometimes do believe, and then you would like to sit down and take a steady clarification on what exactly is wrong. So method-specific myths, if you come to the intrauterine device, you have myths about IUDs causing pelvic infections, which is not substantiated in studies. The study in China, which spoke about an increased risk of infection in the first 3 weeks and months of insertion, was 32 years old. So that was 1988. And after that, there have been several studies which hasn't really said that if an intrauterine device is placed under the sterile conditions in which it's supposed to be inserted, it does increase pelvic infections. IUDs cause ectopic pregnancy. That's not correct. But if it's a failed IUD pregnancy, there's a little more chance of it being an ectopic, but the chance of failing are very less, as a 99% or more than that protection of against an unwanted pregnancy in the first place. IUDs cause heavy periods. A small percentage of women for a short period of time may experience increased bleeding, which usually settles with time, may not need medication or may need some medication. IUD use only after the baby, not true. You can use it in the nulliparous, you can use it in the teenagers. It's not a big no-no as was once thought before. But yes, in our clinical practice, there are few takers for that. But at the same time, it's not a no-no. It can be done. In our clinical practice, we do see people who are sexually active much before in their teens, and people who don't want to use hormonal pills or have hesitancy for, or are non-compliant for them. This is definitely one of the options. IUD causes infertility. We know it's there's no scientific evidence to show that. Should not be inserted immediately after giving birth. This was a myth which was 15 years ago. It's busted long since, and postpartum IUD over the last 12 years introduced by the government of India is a big thrust point for the basket of contraception. It's a well-researched intervention used globally. Method-specific myths when you're looking at the oral contraceptives, there's a myth about the date of starting pills. A lot of us get confused, a lot of the patients get confused. However much you write it down in your prescription and you try to explain to them, sometimes it doesn't always set in. When do I have to take the first tablet? And then you turn around the packet and you see the arrows are moving in one direction, and then your tablets are having in another direction. And then suddenly you get panicky. The doctor, I am not having the tablets properly, the arrows are in this direction, and then that's a problem. So generally speaking, simply, we know you can start in the first 5 days of the period, or you can start a quick start any time of the period where you need to have a backup for a reasonable duration of time. Pills cause cancer. Well, that's something which needs a longer discussion than what we can cover here. Pills and cancer is a big discussion by itself, but simplifying all that, it depends on how long you're using the pill, which cancer you're talking about. There are few cancers which are protective, few cancers which have a slight increased risk during the use of pills, which come down, and breast cancer being the first one, but usually after 5 to 10 years, not in the first 1 or 2 years, which usually people mostly have. Pills cause weight gain. No evidence to suggest that. A lot of people have that feeling that it causes weight gain, but there's nothing to suggest that. Causes infertility. No evidence at all. Pill breaks are essential. We have often see that in our clinical practice, even it may come from gynecologists or it may come from general practitioners. After 6 months or 1 year, they have a break in the pill intake, and that is, they think that it may be a bad thing, a washout time where there's no evidence to suggest that this is required or is at all necessary. Pills cause venous thromboembolic risk. Yes, there is a slightly increased risk of venous thromboembolism, much less than what is there for a pregnancy. And the absolute numbers, when you bring them out, are minimal, and but needs to be brought out. And again, of course, a history needs to be elicited before the first prescription of a oral contraceptive. You need to know that past medical history, family history, to rule out things which may already exist and make her ineligible to use hormonal contraception. Pills cause congenital anomalies. Yes, people did think at one point of time, if by mistake or inadvertently you were taking pills during your undetected pregnancy, that may cause harm to the baby, but there is nothing to suggest that anymore, and it's not a reason to go for a termination. So method-specific myths, when you talk about sterilization, there is some myths are that only certain women can undergo sterilization. That's not true. Most women can undergo sterilization. There are long-term health risks of sterilization. There's a lot of myths about that, mental health, physical health, but there's nothing known about that, which is very well described in medical literature. Sterilization is thought to be 100% effective, but failure, we know, is a possibility, and chances are there which remain that there may be failures, and to a small extent more if it's happening during a cesarean section or during a delivery, just after a delivery. Vasectomy, similarly, we has a very high problem about affecting libido. That's what they think, but it has no relation to that at all. And that is one of the reasons why the vasectomy drives being done by the government of India does not seem to be working all over the country, because according to the NFHS 5 data, which has recently been published a few months ago, it still remains 0.3, and it's the same as what it used to be 5 to 6 years ago. This is one of the different leaflets which have come up from one pharma partner about myths and facts of contraception a few years ago, where they've highlighted all the contraceptives, the most effective, the least effective, and have got some write-up along with that. And here's in just a one-page leaflet, the different methods of contraception and some of the facts with the myths next to each other, so that you can just try to, at a one glance, try to see some amount of information can be passed across. So the last slide, how to conquer myths with facts. So now we know that what the myths are, a lot of, and what I've covered is not a comprehensive list. Of course, there are many more myths which I may not have covered in this presentation, something which you know, something which you have heard about, and something which you keep on hearing, because some of it, it's not that we have done enough or learned enough, because we're learning every day. So how to conquer the myths with facts? So awareness and sensitization seminars and camps at different levels and across different stakeholders is something which we continue to do, and possibly will. Every drop in the ocean counts, so we would make a difference, and we would touch some people whenever, at each possible seminar when we do these programs. Academic sessions with healthcare providers. Yes, start pointing our fingers to us first, obstetricians and gynecologists, members of FOXI, and then also you look at general practitioners, other practitioners or other healthcare providers, our colleagues of other specialties. IEC material with pictorial images, that sometimes is more helpful. As I said, we can have our medical companies to provide more, the people who are there in involved in contraceptive products, to have more material with pictorial images of myths and facts, which we can put up in our clinic, or we can display or give to patients to read if it's a small leaflet, and that would give them some information which would be helpful. Positive messaging of birth control in the media. Media hardly reports on health. Media hardly reports on positive messages in health. They like sensitization, which doesn't always come in the healthcare industry. Individual counseling at every opportunity in the clinic. So that's something which always is there. Any discussion on contraception, any discussion in family planning. So we bring this up. So any reproductive health woman who comes to the clinic, if she or needs birth control, that has to be discussed. Ending with a quote from Carl Sagan. It is certain certainly true that all beliefs and all myths are worthy of a respectful hearing. It is not true that all folk beliefs are equally valid if we're talking not about an internal mindset, but about understanding of the external reality. Thank you very much. Thank you, Raki. Again, congratulations on your good work on the Endolit series. And thank you for the entire team who was there helping you out with this.
Thank you, Dr. Basab. It was indeed in-depth and dil se talk, I would like to say, and it was wonderful hearing you. Over to you, Chetan.
Thank you, sir. Thank you for that wonderful talk. Moving ahead, we come to our last but a very important session, a panel discussion on non-contraceptive use of oral contraceptive pills. And it's by Dr. Jaideep Tank, sir. I will share the screen and I will show myself his CV. I will just give me a second. Can you see?
Yes, sir. Yes, we can see.
Why am I not able to?
You're sure.
Progesterone
immunomodulation you've shared.
Ek minute.
This is your talk. What to share?
Something different popped up. Okay.
So he's doing multitasking.
Give me a minute, huh?
Basically, Dr. Jaideep Tank, all of us know that whatever topic given to him he would be doing justice to it. And he's a person who has a lot of knowledge, in-depth knowledge, and he's an extempore person. And everything is there in his gray matter, whatever you ask for. Let it be anything and everything, and he will come up with the answers A, B, C, D, E. And it has to be followed in that format only. If I'm right, Dr. Basaf?
Yeah, absolutely.
I don't know.
Absolutely.
Is it possible for us to see it? No.
Yeah, he's the man who touches everything and it turns gold. So that's what we just.
Yes. And I can introduce him. As we all know that Dr. Tang sir is past Secretary General of FOXI. He's just handed over. And secondly, he is the Secretary General of AOFOG, if I'm not mistaken. And Dr. Tang,
very soon. So
yeah, waiting for him to see as a president of FOXI also.
Thank you, Raki. Chaitanya, it's all right. I'll go ahead and.
I just got it. So if I can just show that.
Yeah.
Can you see now?
Yeah.
Okay. So if you can read it, Raki ma'am.
He's the Secretary General of FOXI.
I think Raki already introduced me so nicely. How do you want to do the introduction of the panelists? Chaitanya, would you like to?
Yes, I will do.
Yes, please go ahead. Thank you.
So we have panelists. Let me start with the introduction for the panelists. Dr. Vijayalakshmi Gnanashekaran. She is the Associate Professor of Obstetrics and Gynecology at ACS Medical College and Hospital. She was formerly an Associate Professor of OBGYN at Karpaga Vinayaka Medical College and Meenakshi Medical College and RI. She's a consultant OBGYN, Chintamani Hospital, Annagar East, Treasurer of Tamil Nadu Federation of Obstetrics and Gynecology, Executive Committee member of OGSSI, and her fields of interest are high-risk obstetrics, adolescent gynecology, and infertility. Welcome, ma'am. Dr. Munjal Pandya. He's an Assistant Professor at AMCMT Medical College, Ahmedabad, Gujarat, Honorary Secretary of Ahmedabad Obstetrics and Gynecological Society for the current year. Received Series Daftari Young Talent Award from AOGS for the year 2017-18. Co-edited book on male infertility in January 2019. Winner of Dr. Kamini Rao West Zone Yuva FOXI Oration year 2021. Has published many papers and chapters, and hobbies are painting, guitar, singing, writing, tennis, and photography. Welcome, Dr. Munjal. Dr. Sujata Patnaik. She's an assistant professor of OBGYN at Andhra Medical College. Completed her MBBS from VSS Medical College, Orissa, and post-graduation from Andhra Medical College. received several gold medals during undergraduation and was best outgoing student of her batch, presented lectures in local CMEs, and was an organizing secretary of South Zone Yuva Foxy Conference 2020. Welcome, ma'am. Dr. Ashish Kai, he's a vice president. He's director of Arunachal. No, he's a director of Asha Kiran Hospitals, Baner, Pune, Asha IVF Center, Pune, director Arunachal IVF Center, vice president Pune OBGYN Society 2018-19, then librarian of Maharashtra chapter IAG 2019-2021, executive member National ISA 2018-2020, chairman Amox Infertility Committee 2016-2020, executive member Maharashtra ISAR, executive member of IAG, Champions ISAR Award 2020. He was an executive president of Pune OBGYN Society, and he is recipient of Kamini Rao Oration 2017, Foxy Future Award 2017, and Young Achievers Award POGS 2017, and he is going to be the next General Secretary for Pune Obstetrics and Gynecology for the year 2022-23. Welcome, Dr. Ashish. Dr. Kalpana Singh, she is the founder, joint secretary of Indian Fertility Society Bihar chapter, treasurer of IFS Bihar chapter, member of curriculum committee surgical specialty MCI, co-chairperson endoscopy committee POGS, endoscopic surgeon and a fertility specialist. More than 25 publications she has in her credit in national and international journals. Best paper gold medal award in embryology section in National Conference Fertivision in 2018, and best paper award at GFMCon 2018. Dr. Surekha Tayade, she is a professor and unit head at JNMC Savangi Varda, teacher, trainer, guide, mentor since last 20 years. Chairperson for the Global Women's Health Task Force Network TUFS USA, founding member and vice chair Women and Health Together for the Future, National Mentor Quality Improvement Laksha Program, Master Trainer Emergency Obstetrics Care, Expert Committee Member National Guidelines for Obstetrics HDU ICU, co-leader Maternal Near Miss Project, and co-leader for Maternal Death Audit Project. Dr. Geeta Monkey, she's worked in the health department of Jharkhand, worked in her own hospital, Sai Sevayatan Hospital and IVF Center, worked in Riyadh, Saudi Arabia as specialist. She's secretary of the Ranchi Obstetrics and Gynec Society 2019-2020, president of IMA Ramgarh, and chairperson of ISOPAP 2019. Dr. Susila, she is consultant obstetrics and gynecology, Latha Super Specialties Vijayawada and Samatha Multi Specialties Mangalgiri, vice president of Vijayawada OBGYN Society, secretary of Vijayawada Menopause Society, member of MTP Committee Foxy, organizing secretary first APCOG 2015 and Yuva Foxy South Zone 2018, trainer for certificate course on contraception in clinical practice conducted by United Nations Population Fund and Public Health Foundation of India, Dhira and RAC master trainer, and awarded first prize for best photography of indoor and outdoor plants conducted by Foxy on World Environmental Day. And Dr. Raki Singh, let me go back to her. Yes. She's the director at Abalone Clinic, Maternity and Fertility and IVF Center.
Okay, it's okay. Don't introduce me.
Okay. Okay. Over to you, sir.
Thank you.
I will
very
stop
much.
my sharing the screen. Yes, sir.
Yeah, I'm just sharing my PPT. I think I shared the wrong thing. 1 second. Right. So I hope my slide is seen.
Yes, sir.
And that
Yes,
I'm
sir.
audible. The first slide is, of course, the flyer of the program. Let me begin by acknowledging the office bearers of Foxy, Shanta, the president, Madhuri, the secretary, and of course my old and very dear friend Basab, who just gave such a fantastic talk, the vice president of Foxy. You know, I've just recently finished as the Secretary General of Foxy. And even now when someone says Secretary General, I find myself getting up a little bit out of the chair. And as Secretary General, really, one of my greatest happiness came from when there were collaborations between committees of Foxy or between organizations in general. And I'm delighted that this initiative led by Rakhi from the Endocrinology Committee, Niharika from the YTP Committee, and Kalyan from the Public Awareness Committee is doing so well. I must especially acknowledge Rakhi. She is doing so many series that I think she might be feeling like Virat Kohli or Mahendra Singh Dhoni, who keep on playing IPL series and Test series and One Day series, all at pretty much the same time. So congratulations, Rakhi, on
Oh God, thank you, sir.
Fantastic work that you're doing. I must acknowledge all the coordinators, again, Rakhi, Kalyan, and Niharika, and Charmila, and the conveners, Dr. Nagendra, Dr. Chandrika, Chaitanya, and Meenu. We've heard some wonderful talks today, one by Ameya, one by Raju, and one by Basab. And I think all of them have focused on the fact that although we know a lot about contraceptives, we still need to know much more about them. And really, Rakhi, I'm delighted to have this absolutely wonderful, very erudite, and very prominent panel to help us look at the non-contraceptive benefits of pills, some things which we don't always talk about. The way I thought to do the panel discussion was I'll give a brief introduction to the topic, and then we will talk about the menstrual benefits in PCOS and hyperandrogenism, some harm reduction strategies that can accrue from oral contraceptive pills, and lastly, talk about something which I believe we don't focus enough on, and that is the role of contraceptive pills in IVF cycles. And that will be the last part of the presentation. So let me begin with this quite wonderful quotation from Spike Mulligan, who said, "Contraceptives should be used on every conceivable occasion." For me, it speaks to the cultural impact of oral contraceptive pills, because Spike Mulligan, of course, was not a doctor. He was a stand-up comedian. And the fact that even he could talk about oral contraceptives quite clearly shows the impact which oral contraceptives have had on culture. But beyond culture, oral contraceptive pills and contraception in general are, as Louis Slaughter said, not an option. They are a basic health necessity because they are actually one of the things which reduce maternal mortality almost directly. Therefore, there has always been more to the pill than contraception. Pills, particularly in the 1960s in the West, have been looked upon as tools of women's emancipation. They have been looked upon as tools of bringing about reproductive autonomy to women. And perhaps that's why the pills were so controversial. Basab talked about myths and facts of pills. And I cannot emphasize this enough, that besides contraception, pills have got several benefits. And I think that is what our panel is going to focus on, both as a way of demolishing some myths around oral contraceptive pills, as well as emphasizing that if you're going to use contraceptives, why not use contraceptives which will provide other health benefits also? You know, when I was thinking about the panel, I was wondering how to conduct the panel. Should I conduct it like someone who probably had a low ABGAR score at the time of delivery? Or should I conduct it like someone, I'm not going to take names here because I know this is getting recorded. Or should I conduct it like someone who thinks they know everything? Or should I not allow my panelists to speak at all and just keep on talking about how Foxy needs to know about the myths of and benefits of contraception? And finally, I decided that let me try and make a conversation between me and the panelists. Like Larry King, I don't know how many of you have seen that movie Frost Nixon, probably the greatest set of televised interviews between Sir David Frost and Richard Nixon, and I hope that the panel goes this way. So we know that there are several contraceptives, and we also know that OCs are useful for many other things besides contraception. So let me start with Dr. Vijay Lakshmi here, and this is going to be something like a poll kind of a question. And I want to ask the panelists two things. One is, what is your incidence of using OCs for contraception? And secondly, do you use OCs for benefits other than contraception? So two questions, quick yes, no kind of a question. Let me start with Dr. Vijay Lakshmi here. Madam.
Thank you, sir. Thank you for the opportunity, the organizers. Of course, definitely, yes, sir. In my day-to-day practice, I feel more usage of OC pills is more for non-contraceptive use in day-to-day practice than even using it as a contraceptive. That is what I feel in my practice.
Absolutely. And what is your incidence of the use of OC pills for contraception? Say 100 couples come to you, and I'm deliberately using the word couples rather than women.
Yeah.
What is your incidence of prescription and
Here,
acceptance of oral contraceptives?
see, they feel it is really cumbersome to take it every day, but so they would like to have a longer method of usage. So in our practice, we see more of IUCD users than an oral pill users here. That is one thing that I have found out.
Thank you, madam. Munjal?
Good evening, sir. Thank you so much, the committee, for this invitation. Actually, in our OPDs, we see the usage of OCPLs more of this regularization of cycle purpose. For contraception, there are very few females, or couples is altogether a different thing. Very few females who turn up for contraceptive purpose OCPLs. We do prescribe it for pubertal menorrhagia or even on extremes of reproductive age for regularization of cycle more than as contraception, sir.
Thank you. I think very, very important points being brought about, which I'll summarize later. Dr. One, do you use contraceptives for non-contraceptive purposes or for the benefits? And two, what is the incidence of OCs being adopted in your practice for contraception? Dr. Sujata? Yeah.
Good evening, sir.
Good evening.
So I mostly I work in the government sector, sir. So in my day-to-day practice, so contraception, OC pills are less used for contraception. Mostly women, they prefer sterilization or PPI-UCD usage. But OC pills we use for regularization of menstrual cycle in reproductive age group, and mostly for controlling of heavy menstrual period in adolescents and for in PCOS women usually.
Thank you. Ashish?
Sir, in my practical use of OC pills are for IVF purpose only when we are doing a batch IVF in different centers, or maybe in particular case where the contraception for the couple is been advised, it's related to the 10 to 20% of the population, which is I'm doing with.
Dr. Kalpana Singh?
Yeah, good evening, sir. And thank you, Rakhi Madam and organizing committee for providing me this opportunity. Sir, here I am using basically oral contraceptive pills mostly for non-contraceptive benefits, because very few couple comes to us for contraceptive benefits. So mostly I'm using for OC pills for cysts, endometriosis, and for IVF cycle, IVF priming.
Thank you, Dr. Kalpana.
84% patients, in fact,
Yes.
use OC pills for contraception in India.
Thank you. Surekha?
Yeah. First of all, thank you, the organizing committee, for the invitation. And I do like to say that I belong to a rural area, medical college. I'm a teacher here. And I would also like to reiterate that when we offer the couple as a cafeteria choice, very few will pick up the OC pills for a contraceptive benefit. Mostly they would like to have, sterilization, or they can use Chaya or IUCD or PPI-UCD, but not OC pills. I can say only 2 to 3% may be the prevalence in my area. And most of the time we are using OC pill for non-contraceptive benefits, the top of which is for PCOS and HMB and regularization of cycle, and many a times for endometriosis or PID prevention that cause that way. So mostly for non-contraceptive benefits.
Thank you, Surekha. Dr. Geeta, I can see that you're here. Yes. We can't hear you, Dr. Geeta. You're not muted, but we can't hear you.
Sir, can you hear me now?
Yes, now we can hear
Yes.
you. Thank you.
Yeah. Thank you, sir, for giving me this opportunity. I'm a junior here, but still have patients. Plenty of patients are coming for the contraception, but they don't accept OC pills. They always say Depo, Provera, or like that, and they say either give sterilize us. Even in second cesarean, they always the baby is premature or whatever mature, they always opt to do the permanent sterilization. That is more convenient for us. But OC pills, they usually deny. And we use
Okay.
OC pills in our abnormality and bleeding, PCOS, and IVF. Mainly I used in this. Okay, thank you, sir.
Yes, ma'am. Thank you. Thank you. Dr. Sushila, ma'am.
Sir, good evening all. So, sir, the non-contraceptive benefits mainly here we use for the menstrual benefits and dysmenorrhea, and in younger group, that is an adolescent group, mainly for the PCOS, sir.
What about contraceptive uptake?
Contraceptive, the acceptance of OC pills is much better than IUCDs, sir, here.
Okay.
So, yeah, the preference is first is anyhow the permanent sterilization followed by the oral contraceptives rather than the IUCD, sir.
So I think there has been some very important points brought about. The first important point is that obviously all the panelists believe that oral contraceptives do have benefits much beyond contraception and have significant health benefits, and that is why most of them actually have patients who get oral contraceptives prescribed for non-contraceptive use more than contraceptive use. The second is that I think we need to focus on the topic which Rakhi has picked for this panel, because if we tell patients that besides contraception, you will also get other benefits, perhaps the uptake of oral contraceptives will be much higher. And therefore, I think, let's move on to the non-conventional uses, as I would call them, of oral contraceptive pills. And we are broadly going to talk about these four non-conventional uses, as I said, preferably in a conversational manner. I may not be able to see all the panelists together on the same screen. So if you have something to say in between, either contrary, hopefully contrary, to make for a more lively discussion, please use the reaction tab and raise your hand so that I can bring you into the conversation. Let me start with Dr. Vijay Lakshmi again. We have spoken already a lot about the menstrual benefits of oral contraceptives. Now, even if you're not using oral contraceptive pills for menorrhagia or heavy menstrual bleeding per se, even with contraceptive use, the oral contraceptive pill still has menstrual benefits. But we are talking about other uses or non-conventional uses. So Dr. Vijay Lakshmi, I'm going to ask you, how often do you use oral contraceptives? And I'm referring to a different age group here, in women in the reproductive age group. I believe that when you talk about heavy menstrual bleeding, you need to look at it in three tranches. You need to look at heavy menstrual bleeding in the adolescence. You need to look at it in the reproductive age group, more particularly after a pregnancy. And you need to look at perimenopausal HMB. So, Dr. Vijay Lakshmi, let me start with you and ask you, how often do you find the need to use OC pills in patients in the reproductive age group? One. Two, how long will you give this oral contraceptive pills for HMB in the reproductive age group? And three, if there is a patient who presents with HMB while lactating, then what contraceptive pill will you use, or what is your preferred method of dealing with it? We are not going to go into the investigations, etc. When we say heavy menstrual bleeding here, we mean everything has been done and there's no organic pathology. The woman does have heavy menstrual bleeding. So Dr. Vijay Lakshmi, how will you use? Which pill will you use? How long will you give the pill? And do you have any particular preference in terms of estrogen dose or progesterone generation of the oral contraceptive pill? Please go ahead, ma'am.
Okay, sir. As you have restricted my heavy menstrual bleeding only to reproductive age group, I will talk only about that. So in my practice, what I do, any case of heavy menstrual bleeding, first line management will definitely be our tranexamic acid and NSAIDs is what I try. Right. And with that, if it is going to subside, I do not use any hormonal method at all. Okay, with that. If it is not going to subside, my practice is definitely to have an endometrial biopsy to confirm what is the finding at there. If it is a proliferative endometrium, that is what is the finding. Then I go ahead and put the patient on only, if it is only a proliferative endometrium, I put them on only progesterone in the second half of the menstrual cycle, and they still do not go for a regular OC pill.
Okay.
If the endometrial sampling is coming as a secretory endometrium, then I decide, no, this patient is a candidate for OC pill. So there I start my oral contraceptive pill. My preference in usage is the traditional one with ethinyl estradiol 30 microgram is what I give along with the progesterone. And I usually, ask them to come back. I give them for a month. I tell them to come back after the withdrawal bleeding the next month and see how it has responded. If she has responded well, I advise her to continue the same tablet cyclically for the next 6 months. And at the end of 6 months, I stop the pill and I observe them and how they are responding, by which time probably 1 or 2 cycles, I also add tranexamic acid along with the oral contraceptive pill. But after that, I keep to only to OC pill for the next, that following that 6 months totally. At the end of 6 months, I stop everything and put her only on tranexamic acid, because then I tell her it is safer to take that. Let us see how you are responding. With that, I feel in my practice, most of the patients have really responded well if it is a simple case without any structural abnormalities, a simple heavy menstrual bleeding. This is what I have felt.
That is exactly what we are talking about. Thank you very much. Very comprehensive answer. OCs are not the first step. OCs have to be given not only for 1 month, but for a prolonged period of time. And if they don't respond, feel free to add tranexamic acid. Thank you very much, Dr. Vijay Lakshmi. That was extremely helpful. Munjal, there is a patient who's got heavy menstrual bleeding. Now she's in breastfeeding. She's just delivered, and you know that it is in those periods, post-abortion, post-delivery, that the HPO axis gets reset and they are more prone to having HMB. So if she's breastfeeding, will you use OC pills first of all? For example, tell her stop breastfeeding and use OC pills, or do we have any other options besides the regular OC pills?
So actually, sir, there are a few options we have with regards to that. One thing is OC pills will definitely reduce the amount of breast milk, and that will hamper actually the nutrition part of the fetus or the neonate. So the first choice would be tranexamic acid. And if at all needed for the purpose of contraception as well as for control of HMB, we would continue with progesterone only pills. The only thing we need to keep in mind is to have that particular time zone of that particular day. If she misses a single pill, that cannot be compensated with taking 2 consecutive pills on the next day. So this is one thing that we need to remind her while doing that. The other invasive option is again LNG IUD that can be explained as PPIOCD, depending on the time that we have or see her after the delivery phase.
Sure,
So,
thank you. Munjal, the progesterone only pills till now, practically the only one we had was with the trade name Cerazette. But we now have another one where we have drospirenone also. I know it's too early. It's just been introduced in our market. But I think that also might be an effective option, particularly because Cerazette was not really available very freely. And you're absolutely right that it's not a good idea to use your regular oral contraceptive pill in breastfeeding women. It's probably better to go with a progesterone only pill, particularly for its effect on breast milk. Thank you for that, Munjal. Dr. Sujata, what about perimenopausal heavy menstrual bleeding? Again, the same set of questions. How long will you give the OC pill? Which OC pill with what dose of estrogen, and which generation of progesterone will you prefer? And how will you monitor, as Dr. Vijay Lakshmi said, 6 months and so on and so forth? Dr. Sujata, perimenopausal heavy menstrual bleeding.
In perimenopausal heavy menstrual bleeding, it is very important that we have to do a endometrial biopsy to rule out any atypia. So our first and foremost investigation should be to do an endometrial biopsy and to see whether there is any atypia or whether the biopsy is without atypia. Then if the biopsy is, there is no evidence of any malignancy, then the first line of management will be probably progesterones, usually in the second half of the cycle, or continuous progesterones throughout the cycle. And if the patient is not responding, then maybe we can use low dose OC pills, and usually with less amount of estrogen. But it's very important that we have to rule out, these people are high risk for diabetes and associated comorbidities like hypertension and obesity. So where the OC pills have got a higher risk of metabolic effects. So we have to do a thorough clinical examination, and if do a GTT,
Yes,
and we have to do a lipid profile also before starting OC pills. And we have to, the duration will be around 3 months. And after that, I would like to do a review again to see how they are coping up with the OC pills. And any low dose OC pills will be good for this age group of people. So.
Thank you. Thank you. So Dr. Vijay Lakshmi had something to add. I think she had raised her hand. Dr. Vijay Lakshmi.
Yes, sir. Regarding the postpartum woman, I just wanted to say, we need to definitely look at why she is having that heavy menstrual bleeding, whether there is any retained placental bit there, instead of just starting her off straight away on the tablets. So that is one thing which I wanted to say. Otherwise, I agree with what Dr. Munjal had said, everything.
Right. So just for this thing, I fully agree. Every patient before she started on medication obviously needs to be investigated. There is no question about that. But for the purposes of this panel, let's take things at face value and say that if I say that there is occasion to use OC pills, then there is occasion to use, everything else has been done. Okay, so let's rather than getting into the investigations and so on and so forth. If no other panelist has anything to add about HMB in the perimenopause, I'm going to move to Surekha now, and I'm going to ask her the use of OC pills in adolescents, and I'm particularly interested in your views on the debate between progesterone for heavy menstrual bleeding and combined OC pills for heavy menstrual bleeding in adolescents, taking into consideration the fact that the estrogen, and there is a debate about this, it's by no means cast in stone, whether the estrogen limits the epiphyseal growth of the bones in the adolescent. I understand that that has been a concern which has been expressed in the past, that don't use combined OCs for adolescents for heavy menstrual bleeding, otherwise they may not achieve the height that they are supposed to achieve. So Surekha, your thoughts on OC pills for heavy menstrual bleeding in adolescents?
Yeah, thank you very much. I think that OC pills for heavy menstrual bleeding in adolescents is a very good option. Because the debate about it affecting the bone growth and the actual height, that would be only on the duration. The longer you use, the effect on the bones will be evident. What we are talking of is the arrest of bleeding. The arrest of bleeding can be achieved by two ways. You can have the progesterones, you can use the progesterones, or you could start on with a good OC pill like your Mala N and Mala D. These two, which are available in the government setup, they are very good to arrest the bleeding and to explain the patient very well. Also, these pills are, like we have our type of patients who are rural patients, for them it is a very good option. And I think the arrest of bleeding is also very good. You could use progesterone in the first, the first few days, or to arrest the bleeding in the first cycle, and in the next cycle you could just put her on the OC pill, and you can continue for 3 months, stop and see whether the actual cycle reverts back to normal, and that is how I go about it. I think it's a very good option, and a short duration you can go for.
Okay, so Surekha, you seem to have stirred a bit of a hornet's nest here, because I see 3 raised hands from the panelists. So in order, Dr. Kalpana Singh, anything to add to that?
Yes, sir. Just I would like to add that we have to know when she attained her menarche, and within 2 years of use her menarche, we should avoid using OC pills for many other reasons, because it hampers with the maturity of pituitary hypothalamic axis also. So if it is needed very much, to control her excessive bleeding, then one should use for lowest possible duration. But otherwise, we should try to manage by using progesterone only, that too which does not affect the pituitary hypothalamic axis, like natural progesterones would be preferred in adolescent age group. This is my take on this. And we should use it cyclically, because most of the time it is anovulatory, and sometimes it is because of the coagulopathy or hypothyroidism, then there is no role of any hormonal medication.
Absolutely. Thank you. So I think two important points which both Surekha and Dr. Kalpana. Dr. Kalpana, you could lower your hand so that when you raise it again, I know that it's a new hand.
Yes.
Two important points. One is don't use OCs lightly. I think Surekha, you mentioned that you would like to use OCs, particularly when you want to arrest an acute episode of menorrhagia or heavy menstrual bleeding, and use it for a limited period of time. Ashish?
Yes, sir. Thank you, sir, for asking me. What I feel, sir, in adolescent heavy menstrual bleeding is mainly because of the HPO axis, which is not that much properly formed in an early age group. So whenever you are talking about a heavy menstrual bleeding, it is wiser to use a progesterone first. If it is not been controlled, then adding a low dose of OC pills containing low estrogen content. That could be an appropriate way of going forward, sir.
Thank you, Ashish. Munjal?
Sir, I just wanted to add one thing with regards to that particular age group. I have read the guidelines that is like a gray zone. They say that do not start OCPLs, any kind of OCPLs, at least before 14 years of age. And some of the guidelines would suggest 16 years of age. And this is specifically so with pertaining to the hirsutism or the changes of adolescent PCOS that for which the dermatologist would start the anti-androgen containing OCPLs. So we need to stay in the loop as a multidisciplinary approach and stop them doing so. That is what I wanted to say.
So thank you, Munjal. There is room for a lot of discussion here, of course. And I'm thankful to all the inputs that have come. Yes, Surekha, of course.
Yeah, I would just like to add in what Dr. Munjal said regarding the cyproteran acetate containing the OCPL. That is regarding PCOS. What we're talking here is now HMB, and rightly said, when we divide the adolescent period, the early adolescent and the mid-adolescent and the late adolescent, and the late adolescent period, I think would be a better one for using the OCPL. And of course, the early adolescent, we never use the OCPL. That should be the take-home message.
Absolutely. Thank you so much. I think very important messages coming out here. Dr. Geeta, if I can bring you in here and ask you about your choice of oral contraceptive pills for hyperandrogenism. Now, I'm not getting into that whole debate of diagnosis with the Rotterdam criteria and the Amsterdam criteria and the NIH criteria and the new publication from TEED, which talks about so many other criteria. We make an assumption that this is a patient who's got PCOS. She has hyperandrogenism. Now she needs OC pills. So which OC pill will you use? Estrogen, anti-androgen, so on and so forth. And for how long will you give it? Dr. Geeta?
So I usually use this low dose OC pills, and they're working very well. Usually we want to subside the androgenic factors. So actually, this is very good to give them combined pills, but combined pills, and this is for 3 to 6 months, and do their I mean to say, go through the ultrasound, see there whether they have PCOS. Still they have the ovary is still showing the androgenic PCOS, or if anything else, we can go for the hormonal evaluation.
Absolutely.
Thank you, sir.
Thank you. So I think you said combined pills, preferably with anti-androgens and so on. So Dr. Kalpana Singh has raised her hand, but before I ask her to come in, I'll ask Dr. Sushila whether you would use a different variety of OC pills if you're looking at, say, hyperandrogenism with hirsutism, etc. vis-a-vis a patient who presents only with acne. Would you make a distinction in these two things and use a different variety of OC pills for this? Or would you use the same OC pill, which is the one with cyproterone, etc.?
Sir, again, here it is, if it is acne, it indicates it is hyperandrogenism. So part of the spectrum. So here, usually the patient presents with hirsutism, acne, seborrhea, and all these factors. So commonly, we use ethinyl estradiol with either drospirenone, dinogest, or cyprotenone. So basically, in case of drospirenone works better in case of acne, and followed by cyproterone and then the dinogest. So
Okay.
I would prefer to go with the drospirenone in this case.
Okay, thank you. And for how long will you let the patient take these pills before you say that
So
either it's
usually,
working
yeah.
or...
So usually most of the patient, they do respond in first 2 months.
Okay.
We can see them after the 6 months also. We can ask them to continue for 12 months before she goes for the lifestyle modification where the hyperandrogenic factors come down. So sometimes it may take 6 years also in this adolescent group.
Okay, so there is really no reason to stop unless it's really required. Dr. Kalpana Singh.
Yes, sir. I just wanted to add that so far the duration of pills is concerned in these cases, because most of the time it takes 9 months to 1 year for hyperandrogenism or hirsutism to get corrected. So it's for this effect, it should be used for more than 1.5 years, something like that. Then only the effect would be evident. Otherwise, if we stop earlier, then hyperandrogenism and hirsutism may not get corrected.
Right. So it is a long-term treatment. Dr. Vijay Lakshmi, you had raised your hand and then you took it down. So
Dr. Sushila answered, sir.
Dr.
I agree with what Dr. Sushila Madam.
Okay. Thank you. Munjal?
Sir, I just wanted to ask about one thing only, that is DNG ethinyl estradiol. They are to be, they are recommended in two forms. One is cyclical form and the other one is continuous. So what is the take on that particular regime, which is to be used for that? That's it.
Dr. Geeta, what would you prefer, cyclical or continuous?
Cyclical, sir.
Cyclical.
Continuous, they often, if there is no bleeding, they say, what happened to my menstrual cycle? You have given something which is not accepted. So we have to give cyclical, sir.
Sure. Dr. Sushila has raised her hand.
So when we use the cyproterone acetate, it is not FDA approved contraceptive. So definitely the pregnancy can occur and we have to see for the withdrawal. That is every month. Otherwise, we have to go for a pregnancy test. So because it causes masculinization of the virilization of the female fetus. So definitely it is, in case of cyproterone, definitely it is a cyclical method. Other two, we can give a continuous method depending upon the patient's need.
Inclination. Absolutely. Thank you. Wonderful input. Ashish?
Yes, sir. I was talking about the duration of using this particular COCs or maybe a cyproterone acetate, depending upon the androgenic scoring, sir. How much is the androgen excess and what are the scorings of it? If it is on the higher side, we can use it for 6 months and then we can take a call whether to discontinue or continue again for the next 6 months.
Right. So thank you, Ashish. So you're essentially saying titrated against the severity of the problem, really. There is a controversy, of course, particularly in the latest publication, which talks about how do you actually evaluate severity? And there is controversy about that, but we are not getting into that now. I think Dr. Sushila, did you raise your hand? And then Dr. Chandrika had raised her hand.
Yes, sir. So in case of hirsutism, when we start with a OC pill, that is either of the three, but we do not get a good response, there is no need to switch over to other OCP, but we have to go for an anti-androgen like spironolactone or a flutamide, but not to interchange between the OCPs.
Sure. Thank you. I think that's again a very important input. Dr. Chandrika, you want
Sir, what I understand from the PCOS guidelines is that when we are using an anti-androgen based OCP for treatment of hyperandrogenism, minimum clinical response is what is more important. What they present with. And then 1 second, sir, excuse me.
So that's okay, Dr. Chandrika. We are
sorry.
happy to hear. Yes.
Yeah, so
I think even Surekha has dogs, so she
yeah,
must know.
yes, it's basically the clinical response is what we are looking at, and then the acne is the first one to go or respond early. So by 6 months minimum for acne, and hirsutism minimum of 1 year, and for alopecia, there's hyperandrogenic alopecia minimum of 2 years is what is recommended for clinical improvement of hyperandrogen signs.
Okay, thank you. Surekha, you're saying something?
Yeah, regarding acne, we also prescribe some antibiotics with these ossipils because that's very important. But there is a myth that antibiotic, will reduce the efficacy and all. But as we are not prescribing for contraceptive, this is for non-contraceptive benefit. So we have to remember that when we are prescribing, ossipils, we have to talk about acne and antibiotic use together, which is proven to be beneficial. So we can prescribe the antibiotic and ossipil together here.
Absolutely. Absolutely. Thank you very much. I'm going to go back to Dr. Vijay Lakshmi now because I think we've gone through 2 rounds of all the panelists, and I'm going to ask her, OC pills have actually been suggested as a harm reduction strategy for preventing ovarian cysts. But you have this clinical situation sometimes where the patient comes to you with a sonography report which says 3 centimeter clear cyst or 3 centimeter corpus luteum cyst. And then sometimes she's given OC pills for 2-3 months and then said, do a sonography again after 2-3 months and see, whether that cyst is still there or not. I have never really, been very fond of this because you can maybe prevent an ovarian cyst because of the fact that OC pills inhibit ovulation. But do you think that OC pills are actually effective in taking care of a cyst that is already there? Or is it just a coincidence that after 2-3 months when the patient goes for a sonography, the cyst is no longer there?
Sir, in my practical experience, I have seen instead of 3 months, 6 months when I have prescribed OC pills, functional cysts do disappear. It may be coincidental as what you said, but it may be because of the medication also. An OC pill for a duration of 6 months definitely seems to reduce the functional cyst in size, provided they are only functional. It has to satisfy those criteria and not an endometriotic cyst or anything like that. Then it definitely disappears. Thank you.
Thank you. So that segues us very nicely. Surekha, you wanted to add something?
I just wanted to agree to disagree here that the OC pill actually has any effect on that 2 to 3 centimeter cyst which is there. If there has been publications here also which have compared, those who were given the OC pills and those who were not given the OC pills, and they have come to the conclusion that there is actually no statistical difference between these 2 groups, and it may just be a coincidence. Many a times we see that these people are patients are receiving the OC pill for that 3 centimeter or 2 centimeter cyst, but I don't think it has any effect, the OC pill which has been, if you just allow them to be like that and just observe also after 2-3 months, it's going to regress, I think.
Okay. So it's good that there is some disagreement. We were all agreeing with each other very nicely so far. And really speaking, Surekha and Dr. Vijay Lakshmi, it is anybody's guess as to whether that OC pill has an effect or not. What is clear, however, is that the use of the OC pills will probably prevent another functional cyst from coming up. So to that extent, certainly the OC pill will be helpful, but whether it will take care of that functional cyst or not.
And also as a placebo.
And also as a placebo.
Because
and it will also provide contraception. So, yes. So thank you. Munjal, I'm moving on to you now, and I'm going to ask you about the role of OC pills in endometriosis. We'll have to hurry up a quick because I think we have only 15 minutes left and there are a whole lot of indications to go through. But Munjal, if you have a patient where there is a presumptive endometriosis, and this is typically the younger age group, unmarried girls who present with dysmenorrhea and say a 3-4 centimeter so-called chocolate cyst. These pathologists must be hungry all the time. They have Swiss cheese appearance, chocolate cysts, and so on and so forth. So you have this presumptive diagnosis of endometriosis. It has always been my thought that, endometriosis needs to be triaged into symptomatic and asymptomatic. And you leave the asymptomatic group alone and treat the symptomatic group. So you have this, let's say around 22-year-old. She's come with an ovarian cyst, dysmenorrhea, perhaps not very debilitating. Will you start her on OC pills? If you will start her, how long will you give the OC pills? And do you really think that OC pills have a beneficial effect on endometriosis in two terms? One, in preventing progression of the disease, and two, in a therapeutic way for that endometriosis. Munjal?
So basically, there are three things. One is my first choice would be continuous progesterone. With regards to like from residency days, it has been found to be effective in reducing symptoms drastically. It is a cheaper option. That is one thing. The other option again would be Dynogest. In now more recent days, it again has a good impact with regards to menstrual bleeding as well as the pain component. That is like over the period of 2 to 3 months, it will take for that. And third option will be ocipils, and definitely the mechanism would stay the same. It will be like suppression of ovarian function along with atrophy of the endometriotic tissue. The only point I would like to highlight is endometriosis does not actually get cured. It gets a halt with regards to any of the medical management. It will not progress with regards to the supportive medical management that needs to be explained when we are prescribing ocipils or any other medication to this particular patients. And along with the symptoms, the purpose would be seen as if they are waiting for become fertile, then it will be like addition of surgical component afterwards accordingly with the decision making process involving the particular couples.
Thank you. Thank you, Munjal. Obviously, OC pills are perhaps a good option, but perhaps the newer ones which have Dynogest or the Dynogest alone pills, as you said, the progesterone only pills are also equally important in the context of endometriosis. Let me, Surekha, yes?
I think many a times the OCPIL or the medical management is used post-surgically. Post-surgically also to keep the endometriosis in a regressive phase. I think it is good if we can use either the OCPIL or the danazol or whatever the medical management. It would be post-surgically, and we have to remember that the dysmenorrhea actually would go off if we use, would be lessened, the pain will be less. But if you talk of dyspareunia, then it may not be, responding to the OCPIL. So we have to explain to the patient what would be benefited and what would not, how long a period it would take and all that.
So I think here you have to make a distinction between patients who present with infertility and patients who present with pain. You would use OC pills for patients who present with pain, but not really use them in patients who present with infertility, because there is good evidence to show that in patients who present with infertility, adding an agent which either causes anovulation or suppresses to a certain extent actually causes a reduction in pregnancy rates. And it's perhaps a waste of time. So I think you need to
mostly
make
the patients who are presenting with infertility would like to conceive immediately after the surgical procedure. In fact, even the next 2-3 cycles, they would like to conceive. So that's why there we would not like to use the OCPIL. But those who have probably the pain is the one which is the factor, then there the OCPIL would work better.
Absolutely. Thank you. Ashish, you have raised your hand. Surekha, could you put your hand down so that I know
regarding the endometriosis, it is a symptomatic and asymptomatic, as rightly said by you. If it is a symptomatic, definitely we are going to take care by the if the pain is the symptoms, we are going with the Dynogest or maybe a COC. But if the infertility is the question, then if you are using the COC, it increases the gonadotropins, again, your consumption. So for infertility, post-operative also, COC is not the take.
Okay, thank you. I think, yes, I sort of agree with you. It's not the pick, but it is one of the options. But for pain, I would personally prefer GnRH analogs more than anything else. Of course, surgery being the primary treatment. Dr. Sujata, we see patients who have myomas. And again, I think here we need to distinguish between patients who have symptomatic vis-a-vis asymptomatic myomas. Do you actually think that the use of OC pills could treat myomas to a certain extent, or are we only sort of looking at the symptomatology of the myoma when you use OC pills for my patients with myomas?
Sir, I personally feel the symptomatology of myoma, that is associated heavy menstrual bleeding or the pain component, can be decreased with use of OC pills. But as per se, literature says the size of myoma reduces and there is a prevention. But I haven't seen the myoma size of the myoma getting benefited with OC pills. So usually the symptomatology gets corrected with the use of OC pills.
Okay. Thank you. So I think it's important to realize this, that OC pills are not a treatment for myoma. They are only a sort of a band-aid, if one may say so, for the symptoms. Thank you, Dr. Sujata. Dr. Sushila, I'm going to ask you this. What do you think is the role of OC pills for benign breast disease? And have you had occasion to actually use it in patients, for example, with nostalgia, cyclical nostalgia, etc.?
So for cyclic mastalgia, it definitely decreases.
Organizers kindly mute Dr. Pratibha. Dr. Pratibha, please mute. No, Dr. Pratibha.
So for the benign breast diseases, sir, basically I haven't used much of OCPs except for the mastalgia, where it definitely decreases the pain, sir. So otherwise, I haven't used OC pills for other this indications where there is a lump and all. So basically, we are like really scared to start any hormone.
Dr. Meenal, please mute yourself. Dr. Meenal Parekh.
So in case of any lump, in case of fibroadenoma, we are very scared and then we want to go for histopathology and all this. But we definitely do not start the OCP, sir.
Okay, thank you. So I'm going to move on and I'm going to talk a little bit about the fact that if you really think about it, pills are actually the first drugs known to humankind which reduce the incidence of cancer. I think this is something that we don't talk about enough. And this is a very old quotation from Sir Malcolm Potts. It's actually from the 80s. It says that if the pill had nothing to do with sex, it would have been hailed as the greatest advance in cancer prevention. Because actually, if you look at women who have taken OC pills, even for a short period of time, they do have a reduced incidence of both endometrial hyperplasia as well as ovarian cancer. I'm not going to ask for thoughts on that because this is a fairly well-established scientific fact. And only to just reiterate that when we talk about the advantages of OC pills, we need to keep on emphasizing, these non-contraceptive benefits. I'm going to move on to the last section of the panel now because I have only 5 minutes left. Rakhi, don't worry, I'm cognizant of the time. And talk a little bit about programming of IVF cycles with OC pills. And I'm going to use 2 minutes here just to share these few quite wonderful studies. We switched to antagonist cycles completely in 2012. And we do a lot of batch IVF all over India. And we were always worried about how to program antagonist cycles. And when this study of Grissinger came out in 2010, we were actually very, very upset because George Grissinger quite unequivocally said that if you use OC pills for programming, you are going to have reduced pregnancy rates. This was contrary to whatever I had read in the past, including the use of OC pills with regard to contraception. It has a washout period. But then the study came from Garcia Velasco in 2011, which compared long agonist protocol with OC pill treated antagonist protocol. It said the results were the same. Another study came out which compared OC pill programming with estradiol valerate programming. Again, results were same. And then Garcia Velasco published a critique of Grissinger's meta-analysis. And I think this speaks to the talk which was there earlier on meta-analysis. And I think some of the fallacies of meta-analysis were, highlighted in the talk. And when Garcia Velasco presented this, he said that the studies which were included in the meta-analysis, unfortunately, were not homogeneous. The studies included both normo and poor responders. The power of the studies were not very good. Different OCs were used, different duration of administration of OCs were used. And most importantly for me, they were wearing pill-free intervals of 2 to 5 days. So I'm going to ask Dr. Kalpana Singh here. One, do you use OCs for programming? And if you use OCs for programming, how do you use them?
Sir, mostly we do not use, because mostly we go by antagonist protocol, and but whenever we use for priming, then the duration we target to be less than 14 days. But sometimes in PCOS patient, if LH is very high, then we do give OC pills for 21 days, and then in that cycle, in subsequent cycle, we do not stimulate, we stimulate the patient in cycle after the OC pills.
Okay.
So we give a gap of 1 month.
Okay.
And we use it for in PCOS patient. But whenever you use for smaller duration, then in subsequent cycles, we go for stimulation. If the OC pill use is for
talking about the use of OC pills in PCOS rather than purely for programming. And for programming, you prefer to have a shorter duration of OC.
Shorter duration, yes.
Ashish, your thoughts?
Sir, I'm using a OC pill for programming of the batches in IVF. It is said that whenever you're using OC pills, you can use the OC pills between 12 to 14 days. This is usually I use. There has to have a OC pill free days for 7 days so that the washing out of the period of the effect of the OC pills are there. And then you can start doing a stimulation, because in a batches, it is helpful for programming the cycles. Nowadays, we can use these OC pills for a shorter time also, so that it can be, instead of OC pills, you can use a progesterone only pills also.
Sure, thank you. And I'm going to talk about progesterone only pills because Ashish, you have a publication on that to talk about the use of MPA in antagonist cycles. Personally speaking, I use a lot of OC pills for programming because we run something like 15 or 17 IVF centers. So we have to program our cycles, otherwise we won't be able to go everywhere. And to tell you the truth, what we have found is that it doesn't matter how many days you use the OC pill. What matters is the interval between the last pill and starting stimulation. The literature currently says 5-day washout period, but we use a 7-day washout period. And our criteria for starting stimulation is that the patient must get her menses before we start stimulation. If you follow these things, you'll find that the results are absolutely the same. Rakhi, you want to pitch in on that, or I can move on?
I have a question for that. If you're telling 7-day gap, if you're giving, and there would be say, dysynchrony of the period withdrawal as you have given, it on the very one day, very same day for all of them. So
it doesn't matter. I look at it this way, Rakhi, and I'm sorry, panelists, I'm taking a little bit of time over here, but I am quite passionate about this topic. There are two sets of evidence. One set of evidence says that whether you start stimulation on day 2, day 3, or day 4 of the menstrual cycle, it doesn't matter. Because you're giving such a high dose of gonadotropins, and supraphysiological dose, the day of starting stimulation doesn't matter. So you have that one set of evidence there. And you have another set of evidence, and this is old evidence, which talks about the washout period of OC pills and says that you need a minimum of 5 to 7 days. So that's why I don't care. If I start stimulation, for example, I stop the OC pill, she gets her period after 3 days, I'm starting stimulation on day 2 or day 3 is absolutely fine. Every patient starts stimulation on the same day, irrespective of the day of menses. That's the principle we follow. But I think this is a discussion for another time.
How much gonadotropin do you give, sir?
Well, that depends from patient to patient, madam. But typically, I have found that with the antagonist protocol and the ability to use agonist as a trigger, we essentially have boiled it down to either 300 units of HMG or 450. And if we are using recombinant FSH, we tend to use either 200 or 300. It's become quite standardized now. IVF has become very, very simple compared to what it used to be once upon a time. I'm sorry to take a little time on that, but this is my last.
Can
yes,
you use the same thing for a natural cycle, sir, instead of your IVF cycle? The same principle?
Well, I'm not a fan of natural cycles, to be perfectly honest. In IVF, I presume you're talking about IVF.
No, no, not about IVF. A person like me who do not practice.
You want to program a natural cycle?
Program a natural cycle.
Yes,
So
the problem is that in the natural cycle, you don't control when you will start stimulating and when the oocyte will recruit. So that 7-day period you will not get. That is the only sort of problem. Yeah. Okay. So Ashish, I'm going to ask you this question because I know you have a publication on this, and that is the use of MPA instead of antagonists in IVF cycles. And I'm happy to have any panelist, pitch in freely. Ashish?
Yes, sir. Thank you, sir. Thank you for recognition of my little bit work. Sir, what we had done in this particularly, instead of like there is always a why we are giving antagonist or agonist in order to prevention of premature Ellis surge. If you are having a same progesterone or a medroxyprogesterone or maybe a dydrogesterone, if you are starting from day 2 till the day of trigger along with the gonadotropins, it also prevents the premature Ellis surge. What we found out, the number of M2 oocytes are the same, and it is a decrease in the cost. So that is the inference when we talked about a progesterone prime protocol as compared to the antagonist, sir.
Thank you, Ashish. And I think this is the way forward for donor cycles or patients where you are anticipating all freeze. So I'm going to end this panel discussion and ask all the panelists to give their take-home messages. Let me start with Dr. Vijay Lakshmi, ma'am.
Sir, one question I have got, sir. We spoke about prevention of cancer, endometrial and this thing, evidence you have already said. They are also saying OCPL causes cervical cancer, one of the this thing. Why is that statement made, sir? Do you really think it does cause cervical cancer? Or how I perceive it is because people are using OCPL, they do not use barrier, as a result of which HPV infection is more, and indirectly it is causing cervical cancer. Is it that way, or directly is there any connection between these two?
No, I think you're absolutely right. I would go with the fact that barrier contraception is not used when oral contraception is adopted. I don't know if any other panelist has anything to add to that.
Because as medical college teachers, whenever we talk about the advantages, side effects, we say it causes increased risk of cervical cancer. Yeah. But then we really feel bad to say that.
I think it has to do with the lack of barrier
contraception. Okay, fine.
And madam, if you could go on to give your take-home message over here.
Thank you very much once again, Dr. Rakhi Singh and all the organizers. It was a wonderful thing to be in your panel, sir. That's the one thing what I wanted to say. We really covered beautifully. And as I said, the first thing what we started, definitely the usage of contraception, I mean, OCPLs is more non-contraceptive, but usage is much, much more than actually the contraceptive usage is what is there. A variety, the entire list that you have put up of all those things we are using it is really such a wonder drug that we have got. And that's what I would like to say. More of non-contraceptive uses. Thank you.
Munjal?
But sir, it is actually like all other drugs, it is a miraculous drug. We need to keep the patient in a loop of the confidence, and we need to counsel and involve the patient and the couple in decision-making process. Thank you.
Thank you. Dr. Sujata?
Thank you, sir, for making me a part of this wonderful discussion. Actually, it has got, it's a wonderful drug and it has got many non-contraceptive benefits, but patient counseling is important to help in continuation of the use of its usage, so that we can yield maximum benefits. That's what I feel.
Thank you. Thank you. Ashish?
Sir, at the outset, I'm really thankful to my friend Rakhi and yourself, sir, for making me a part of this wonderful panel. I must say there are so many teachers, but the master is the one. So you make it in such a small time. Everything is very much covered, sir. Nothing to say more. It has really a wonderful, wonderful time I have done.
Thank you. Dr. Kalpana?
Thank you, Rakhi Madam and sir, for making me part of this panel discussion. I would just like to add that OCPLs are of various type, of various generation, and available in various dose forms. So judicious use should be promoted in various age groups, and contraceptive and non-contraceptive benefits are there. So judicious use is...
Absolutely. Thank you. Thank you. Surekha?
Yeah, first of all, let me thank the organization, Rakhi and Jaideep sir. It was really wonderful. A lot of learnings for me too. And what I would like to say is that OC pills, like Dr. Kalpana has said, it's a wide range available towards us. So we need to individualize our approach when we are prescribing. See, for the contraceptive use, I think a lot of more efforts will be needed to promote, especially in rural areas where people don't have a lot of uptake. But for the non-contraceptive benefits, we do have, again, a huge list where we can use it, but we need to individualize which OC pill to use where. For the PCOS, we need to have the one with the Ciproteron. For the other, the dosage, the lowest dosage may, I think, would be preferable, but that would depend upon what what is the indication of use, what is the age group of use.
Thank you, Sarika. Dr. Geeta? You're muted, madam. Dr. Geeta, you're muted.
Thank you for considering me in this panel discussion. It was a lot today I got from you, sir. Sir, I always say the non-contraceptive approach for this is for medical men, but OC pills should be accepted more in the society. We have to convince to our people to take it very lightly. They are taken very seriously. They don't want to take it because it will going to give us adversity. But I think if we will convince them, they will take it easily, and that gives them more, I mean to say, benefit is very high, and society should be consider this miraculous drug in their day-to-day life. Thank you, sir. Thank you.
Thank you very much, Dr. Geeta. Dr. Sushila, you have the last word.
Sir, thanks for the opportunity. And sir, I would like to add, nowadays there is an increase in premature ovarian failure. That is also an indication where we can use the OC pills, and also in secondary amenorrhea, and also as a part of MHT also, OC pills can be used. And it has to be used judiciously, and we have to explain that they have to take every day. And other thing is extended use or a continuous use helps to prevent anemia, which is a common thing we see in our women. Thank you, sir.
Thank you. Thank you. So I think very important messages coming out here. One is that Rakhi and team, you really selected a great topic, something which is absolutely relevant, particularly for OCs, where it seems that they are used more for non-contraceptive uses than contraceptive uses, something which perhaps also needs a little bit of correction, if I may say so. And the fact is that there are several health benefits of the oral contraceptive pill. And the fact also remains that for really getting the maximum health benefits from OCs, they should probably not be used for very short times. This is the message that at least I got, that 3 months, 6 months, a year, depending on the indication of use. Thank you very much again, Rakhi and the entire team for inviting all of us. And thank you very much to the panelists for a wonderful and very spirited discussion. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you. Thank you very much,
Jaideep, sir, for that wonderful panel discussion. Probably a few years down the line, we will have one more panel discussion moderated by Jaideep, sir. Only the topic for the panel discussion would be contraceptive benefits of pills, rather than non-contraceptive benefit of OC pills.
Yeah. Sir, if I just can add, the biggest hesitation is with the gynecologists themselves. You know, we are so worried about the side effects, and particularly the CVT. That was the reason this article was chosen by the team, so that, you know, all the time we are worried about the side effects. So the biggest hesitation is from the gynec. So we end up using more and for non-contraceptive benefits. Thank you so much for all the panelists and Dr. Sir. Thanks, sir, making it very, very interesting.
We've got Dr. Shobha Goody with us. Ma'am, can you?
Yeah. Just wanted to congratulate you, Rakhi. Wonderful to have all three committees collaborate on this fantastic subject. And of course, all the talks were quite interesting. And the panel was the icing on the cake, I think. And very good contributions from everybody. And Dr.
Final verdict given by Dr.
Yeah.
Dr. Shobha, the Family Welfare Committee chairperson.
Thank you, Raki. The thing, the last comment given by, was it Dr. Chaitanya, who said that contraceptive benefits should be the focus of the next.
Yes.
And
Next talk, it would be
that was a
definitely.
very wonderful concluding comment, I feel. That
We would have that again. We would have with you and all of us doing that again.
Thank you, Raki. Just to bring into perspective that the COCs are by far a very, very favorite contraceptive used across the world. More than 25 million women use this. And in India, it is grossly underused in the contraception basket. It is hardly 2% or 3%, and that is where it needs to increase its use more for the non-contraceptive benefits. But so it has to be industry driven for contraception also. And the last speaker very well said that we should be convinced from within to prescribe. And the take on the cancer cervix, absolutely now there is no convincing statistical evidence that there is a cause and effect relationship. And we all know that cancer cervix is preventable. And giving a vaccine is better than withholding contraceptives. And, screening is a better thing than withholding contraceptives. Yeah. So I think we should say all. Thank you, Raki, for the opportunity. And again, to Dr. Basab and to Dr. Tank, greetings from Family Welfare Committee, and thanks for all the support.
Dr. Tang, the whole panelist, all of them were beautiful, and the whole panel was a rocking one with a full of information. Thank you all for doing it. Great. Thank you.
Thank you, ma'am.
Thank you, ma'am. And at the outset, from all the three committees, I would like to thank our esteemed faculty and also all the panelists and all the delegates who have logged in, even though we have overshooted the time, for being there. And I'm thankful to all my coordinators, Chaitanya, Meenu Handa, Dr. Chandrika, and all the rest, Dr. Nagendra sir also, and all of them for being there for me. And apart from that, I cannot end my thanks without marking the thanksgiving for the Zydus team for being there. And hope to meet you all soon again with the Endolit first on 1st of March. Again, we're going to be back on the 1st of March with the same time and the same link.
Thank you, ma'am.
Thank you. Good night.
Thank you, sir. Thank you, Dr. Raki.
Thank
Good night, everyone. Good night.
Good night, everyone.
Good night. Good night.